Well, hello everyone, and welcome to our case conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I'm a CL psychiatrist at Mayo Clinic, and I'll be moderating this event and introducing our speakers. And just as a reminder, this event is one of many in a monthly series of alternations of different types of webinars, case conferences, educational webinars, journal clubs, etc. The next one's going to be on September 13th, Dr. Sarah Andrews, about post-transplant medical adherence. But today's 30 to 45-minute case conference will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then it'll end with a Q&A session. So if you have any questions, put them in the Q&A option of the Zoom Meet. Feel free to use the chat if you want for comments, but we're only going to be answering questions within the Q&A session. Our trainee presenter today is Dr. Natalia Luna Andrade, and she is a PGY3 psychiatry resident here at Mayo Clinic in Rochester, Minnesota. And our CL faculty discussant is Dr. Sanjeev Sockalingam. He is a professor of psychiatry at the University of Toronto, vice president of education, and physician-in-chief at the Center for Addiction and Mental Health, and the psychosocial director at the University Health Network Bariatric Surgery Program. And without further ado, I'm going to hand it over to Dr. Luna Andrade for her presentation. I think you're good to go.
Okay, thank you very much. So we are presenting a case that exemplifies the psychiatric care of a patient undergoing bariatric surgery. The reason for consult is exacerbated depressive symptoms, and the chief complaint is functional decline. The history of present illness is a 37-year-old female that was referred by her PCP for an outpatient evaluation at a tertiary center with bariatric surgery psychiatry specialists. She reported a depressed mood with anhedonia nearly every day since approximately the second postoperative month, despite adherence to her long-term bupropion XL prescription. After she had undergone Roux-en-Y gastric bypass and due to decline in her mood, she had to take a leave of absence from work. She separated from her husband and was finding it hard to complete daily activities like showering, cooking, and grocery shopping due to fatigue. No significant changes were noted on her eating habits aside from decreased appetite. In her past psychiatric history, in her early 20s, she started presenting with symptoms of recurrent major depressive disorder, and she began seeing a psychologist while she was in college. But those symptoms became more prominent, and in her early 30s, her primary doctor started her on sertraline. And there was some partial remission of those symptoms. However, she was still feeling bothered by them, and in her late 30s, the primary doctor switched sertraline to bupropion XL, and that achieved remission of all depressive symptoms. At this time, she had no history of eating disorders and no history of substance use. Her past medical history was relevant for class 3 obesity. She has a body mass index of 45.07, obstructive sleep apnea, chronic knee pain. In the pre-surgical evaluation, it was identified that she struggled with obesity for most of her life. She tried multiple diets, healthy eating, weight loss clinics, and excessive physical exercise. It was noted that she demonstrated several emotional triggers for eating, like feeling nervous, excited, fatigued, or bored. As we mentioned, her medication included bupropion XL, 300 milligrams daily, and she had that chronic knee pain for which she took over the counter ibuprofen, 600 milligrams as needed. No allergies were listed, and her social history was relevant for her being a second generation Mexican American, mother of two. As we mentioned, recently separated from her husband. Her oldest daughter was away in college, and she was living only with her 17-year-old son. She worked full time as a secretary. Alcohol use began after high school. She would only drink on social occasions during college, but there was no history of intoxication or blackouts. And then, over the 5 years prior to surgery, she will probably drink between 1 of 2 glasses of wine per month. Her family history was negative for diabetes or substance use disorder, but it was positive for obesity in both her parents and in multiple siblings. During the physical exam, there was some limited range of motion in active and passive movements and bilateral knee pain elicited by this motion and also with ambulation. The mental status exam was unremarkable, aside from her describing her mood as low, this mood being depressed, and she was affect and mood congruent. The diagnostic evaluation pre surgery included an EKG that was unremarkable with a QTC of 405 and a heart rate of 86, an unremarkable lipid panel, hemoglobin A1C, and TSH. The post surgical evaluation included folate levels and vitamin B12 levels, both that were within expected ranges. So the differential diagnosis that we're looking at includes major depressive disorder episode, a persistent depressive disorder, or an adjustment disorder with depressed mood. And the guiding questions for discussion are: what is the goal of a psychiatric pre-surgical evaluation in candidates for bariatric surgery? And in what way could the anatomic changes in her GI impact the course of her previously diagnosed mood disorder? And with that, I will hand it over to Dr. Sockalingam.
Thank you, Dr. Luna Andrade, for that great case presentation and also for highlighting some of the issues quite relevant to the interplay between kind of CL psychiatrists and general psychiatric effects in bariatric surgery. So I think as part of the first question that you posed in terms of guiding our discussion, which is what are the role and perspective for psychiatric assessment and readiness for bariatric surgery. I think that one builds on the fact that many patients who present for bariatric surgery have high psychiatric illness, rates of psychiatric illness. And that's because obesity is a multi-organ disease. There's a lot of physical health and mental health comorbidities. And the rates of psychiatric illness usually range to lifetime rates up to 70%, depending on the patient population, how that's assessed, with current rates somewhere between 30 and 40%, again, depending on the samples. And the most common psychiatric conditions are often mood disorders such as depression, anxiety, particularly social anxiety, and eating disorders, which predominantly are binge eating disorder. And really the approach to psychiatric assessment for bariatric surgery has really shifted over the last 10 plus years. We often had thought about it as a suitability assessment, a go, no go, or a gatekeeper function. And now we've really shifted to how do we do a more longitudinal readiness assessment. So of course, we want to make sure people are entering bariatric surgery stable in terms of their psychiatric illness, if they have a history of psychiatric illness. But we also want to focus on engagement, identifying other risk factors that may play a role in terms of post-surgery care, because we know things like post-operative eating psychopathology, relapse of psychiatric illness can interfere with the weight loss outcomes for bariatric surgery, but also quality of life and the overall mental health and well-being for patients. So really pre-surgery assessment is, yes, to make sure that someone is stable, ready, prepared, knowledgeable for bariatric surgery, and from a psychiatric standpoint that we can mitigate any acute issues in the perioperative phase, but more so it's about planning for and identifying what kind of supports they may need post-operatively as well. And so the readiness assessments include psychiatric stability and ensuring patients are psychiatrically stable. And those are defined differently in different jurisdictions, but usually focus on domains such as the severity of psychiatric symptoms that someone might have, whether it may be mood, eating psychopathology, anxiety, or other comorbid psychiatric conditions, whether they've had any recent hospitalizations or emergency room visits, self-harm or suicide attempts. And so all this is part of the kind of stability assessment. We also want to understand patients' journey in terms of weight loss and their mental health history, because that'll give us insights in terms of who's in their support system, how their psychiatric symptoms have influenced their care as well, and their management of obesity. In terms of eating psychopathology, we want to make sure that patients don't have severe symptoms of eating disorders like purging, bulimia nervosa, severe binge eating. And of course, that's part of our assessment. And we know that people who have disordered eating or loss of control before surgery, more likely to have it after surgery, and you're more likely to have weight regain or weight recurrence as a result. And then substance use is the other factor. And partly we need patients to not be smoking prior to surgery because it helps with the surgical healing afterwards. And of course, has other life consequences. Alcohol use, and again, for some patients may develop increased alcohol use afterwards, or de novo alcohol use disorder in a proportion of patients, and also other substances that might interfere with weight loss and their psychiatric stability. I think your second question, Dr. Luna Andrade, was related to what to do about medications and after bariatric surgery and the impact of bariatric surgery. We know that two most common types of bariatric surgery are the sleeve gastrectomy and the Roux-en-Y gastric bypass. Laparoscopic bends have dropped significantly due to concerns about long-term efficacy. And of course, there are other procedures that are more malabsorptive in nature that beyond the Roux-en-Y. And, again, our thinking about psychopharmacology in the context of bariatric surgery has shifted. We would probably recommend, because we know there is a malabsorptive component as well as some of the restrictive components, that the sleeve gastrectomy really impacts the gastric pouch, and so that can impact dissolution and of different types of medications. Whereas the Roux-en-Y also has a significant malabsorptive component. Transit time is also affected as a result of this, and this can also lead to abnormalities. And so generally, in terms of pharmacokinetics, we see that there are many studies that looked at antidepressants, and usually that first year after bariatric surgery is the period of where people experience significant malabsorption or a poor absorption of their psychiatric medications, and particularly if they have a Roux-en-Y. And as a result of that, we might see that as a high-risk period for people to have some relapses in their psychiatric symptoms. And as a result, we usually recommend that people are monitored closely for their symptoms for relapse during that time period. There are the SSRIs, like things like sertraline, but also duloxetine, have also been noted to have that impact. We also know extended release preparations require certain pH to dissolve and may need more time to be absorbed as a result of this. And so when possible, we think about pre-surgery, if it's not going to disrupt or destabilize patients and we have enough time to do so, whether there are immediate release preparations of medications that might be useful and may switch patients. We don't do this universally because there's actually a pharmacokinetic study for venlafaxine XR that actually showed no significant malabsorption and in terms of the concentrations of venlafaxine postoperatively. That being said, if we have that time, it may be helpful in terms of absorption. And so then we would monitor patients. And of course, for patients after surgery, we may need to reconsider the preparation of the medication, the dosing of the medication to stabilize patients, and switch in those patients that may have challenges with absorption after surgery. And then the last point I would say is that there are some medications that have a very, very narrow therapeutic window, like lithium. And for patients who have mood disorders or an augmentation, if lithium is being used, that patients on a medication like lithium may require very close monitoring. And there are protocols out there, our centers have developed and published on it as well, where you may need to monitor levels closely because patients before surgery may go on meal replacement to shrink their liver for laparoscopic procedures. which may have impacts on the concentration of lithium levels. And then post-operatively, patients often start with a fluid diet and progress gradually back to a regular diet. And during that time, they may have difficulties with their hydration and fluid intake, which can lead to lithium toxicity. And there are several reports of lithium toxicity post-surgeries, particularly in the first few months after bariatric surgery. So those are some of the considerations, Dr. Luna Andrade, that you posed in terms of some of the questions. But I think, again, that's part of our pharmacological approach in the post-bariatric surgery patient. And with that, I'll hand it back to you to continue our case.
Thank you, Dr. Sockalingam. So our final working diagnosis was major depressive episode exacerbated by post-operative medication absorption changes. So the bariatric surgery psychiatrist recommended to change the bupropion formulation to immediate release with a frequency divided in 2 doses of daily 150 milligrams. In the follow-up, she still continued to voice fatigue and low energy, so the dose was further increased to 450 milligrams twice daily, and that achieved clinical remission of her symptoms. Now, in the 2-year follow-up, she had transitioned from emotional eating to emotional drinking, but she was motivated for treatment and attended a 30-day dual diagnosed residential treatment program and joined AA. In the 4-year follow-up, she had complete remission of the major depressive disorder and alcohol use disorder symptoms. And with that, I will hand it over to Dr. Fipps.
All right. Well, thank you both for your excellent case presentation as well as the great discussion that we had. What we'll do now is this is the Q&A session. And so if you have any questions, put them in the Q&A box instead of in the chat, and we'll get to them as soon as we can. A few things that have already come up, though, that I've found. One of these is this recent hype around the GLP-1 and suicide risk. You mentioned that there was already kind of a higher risk of suicide ideation attempts and non-suicidal self-harm within this population. Are there any things that we know about risk factors, and can you also speak to the GLP-1 stuff that recently came out in the media?
Thanks, Dr. Fipps. So I'm happy to speak on that. So as I mentioned, there are many things that happen post-operatively for patients. And there are reports of an increased risk of suicide and self-harm incidents in patients post-bariatric surgery. Still quite rare, but higher than the general population for post-bariatric surgery patients. Also higher rates of psychiatric healthcare utilization, like outpatient visits, emergency room visits, and inpatient mental health admissions. So some very good epidemiological studies to show that. And so in terms of risk factors, we aren't really clear about the potential risk factors because there's probably a myriad of effects that and factors that actually play a role in these significant kind of increased risks for patients. One is we just talked about malabsorption of medication. So that could definitely play a role if patients aren't adequately followed, monitored. They maybe have relapse of their mood symptoms and resulting suicidal kind of thoughts. We know that substance use disorders might recur afterwards or new onset. And patients for alcohol use, for example, are more likely to get intoxicated with just even a single drink, with higher rates of peak concentration with one drink after bariatric surgery, and also longer time to clear alcohol as well. So we see those altered alcohol levels, which might disinhibit patients afterwards. There may also be weight recurrence or weight regain that might influence it, or body shape image issues related to excess skin folds that might also play a role in terms of kind of suicidal thoughts or suicide attempts. And I would say also expectations. Sometimes patients are coming into surgery despite all the education that they receive, expecting that this will transform their life, including their mental health. And we know the physical health is more likely to be improved in quality of life, but mental quality of life does not move. It improves for most patients, but not for all patients substantially, particularly those with more significant psychiatric comorbidity. And so, all these factors might lead to someone having more impulsive or suicidal ideation and self-harm attempts or completed suicides. And so as a result of that, I think that's where we see this risk. And in terms of GLP-1, there are, from Europe, the databases that have identified this. Again, the indications for GLP-1 are not to be used in people who are suicidal or have kind of psychiatric instability. Nonetheless, it is possible all the same factors associated with weight loss, excluding, of course, like the alterations in alcohol, pharmacokinetics. I think besides that, all these other factors would apply to GLP-1, like changes in the interaction, pre-existing kind of psychiatric illness might be playing a role, body image issues, kind of failed expectations with bariatric surgery could all influence and play a factor. There is currently studies and analysis going on to further understand this, but it's not been seen in the clinical trials for the GLP-1s in terms of self-harm and suicidal ideation. So again, more to come on this, Dr. Fipps, but I think there are some parallels with bariatric surgery that we see with GLP-1s as well.
Excellent. Thank you for that. And there's a lot of questions about the dose of the bupropion. I can go ahead and quell that one just because I was involved in the background of creating this case conference. It's 450 for the whole day. It was split throughout the day, so we're not talking about 450 truly BID. I think that was just a typo within the slides. We've got a lot of questions about specifically different mental health conditions relapsing afterwards. Some of these are around like childhood trauma comes back up and there's reemergence of PTSD symptoms. Some people have had reemergence of depression symptoms. There's a lot of different factors involved with the recurrence and relapse of different mental health conditions. But I was curious if you had thoughts kind of on a few of the different questions that have come up about mental health relapse after surgery.
Yeah, I think trauma is a good one to flag. The initial studies were attuned to some of the prevalence rates for trauma, but with improvement in some of the studies and assessments, we see rates somewhere around 35, 40, 45% in some studies for patients who are coming for bariatric surgery who have a lifetime history of early childhood adversity or trauma specifically. As a result of that, it is not uncommon for patients who may be experiencing changes. So losing weight may be seen as a way for some patients, they're probably not getting paid the attention by people around them or in society that they would if they had lost weight, because people often comment on the weight loss. They may be focusing more attention. That can be triggering for some patients. And they may be more apt to be approached about relationships after bariatric surgery as a result of this. And this may trigger PTSD-like symptoms for patients who have had a history of that as a result. And so again, it's part of the education that I think is needed before surgery to get patients informed about this, particularly those who have that history. And also kind of close monitoring afterwards, because some patients are often likely to say, I'm going to benefit from surgery, so I probably won't focus on this. But these things tend to occur and recur after that 1 year period. And that 1 year period is the honeymoon period after bariatric surgery. We often see kind of 2-3 years beyond is where we see kind of recurrence of some of the psychiatric symptoms as well.
Very nice. Thank you. I got a few around like standardization and or guidelines when it comes to either how do we address and do a standardized approach for pre-surgical evaluation for someone with bariatric surgery, or even like guidelines around psychopharmacology after surgery. Do we have anything around answers regarding that standardization?
Yeah, there are a few few papers out there that have been out. There's one, and I'm disclosing I was a co-author on one of them, was Janelle Coughlin was the first author that really summarizes the kind of current state of psychopharmacology for bariatric surgery, and has some general recommendations. I would say, again, universal switching is not always, it's really tailored to the individual patient, because some patients might have very complex histories, and certain medications have been critical to their stability. And so we don't want to have a knee-jerk reaction to switch people all at once. But it is important, I think, to look at the psychiatric medications. Are there ones that are resulting in increasing weight gain over in recent time that we need to switch? If we have time to do so in collaboration, if we're not the primary prescriber with the prescriber, then two, to see if we do have time, are there immediate release medications that we can switch to? And then there are those that I mentioned are high risk that might need more closer monitoring protocols after surgery. There was a question about certain antidepressants. As I mentioned, the ones that we don't want short-acting medications, because there are reports of SSRI discontinuation in the first few weeks after bariatric surgery, just due to malabsorption. So paroxetine would be one I'd stay away from. But there are studies that show poor absorption of sertraline, citalopram, duloxetine as well in some of these pharmacokinetic studies. And so those were ones I wouldn't tend to use. All the other ones are unclear. I told you venlafaxine XR seems to be okay in a pharmacokinetic study, and that kind of shifted our thinking as well. And so that might be one option, but there are probably others as well that we could use in terms of some of the newer antidepressants, which we don't have data, so that's why we end up using them as a result of that. But I would say really close monitoring dose. We might optimize doses for patients that might be having relapse first, and then consider switching patients that are not responding.
Very good. Another shameless plug that I'll say because of timing purposes is that this webinar is actually based off of the JACLP case conference manuscript that a few of us on this panel did, that goes through the preoperative psychosocial evaluation, psychopharmacology, as well as alcohol use disorder, problematic alcohol use after bariatric surgery, as well as a recorded web presentation that will be done from that regard for ACLP this year as well. So if there are more questions about that, there are other resources that we can give as well from ACLP standard as well. For timing purposes, I appreciate how involved the audience has been. Obviously, we're not able to answer all the questions that come, but out of respect for your time, I'm going to say thank you for your involvement, audience. Thank you for the excellent case presentation, Natalia, and the excellent discussion, Dr. Sockalingam. And don't forget about the upcoming webinar that's occurring on September 13th about post-transplant medical adherence. But otherwise, I say you have a good day, and we'll see you next time.